Hello everyone and welcome to our presentation. I'm Gautami Mangu and I'm going to talk about an interesting case of Lemierre syndrome, an external jugular vein precipitated by COVID-19 infection. This is a 31-year-old male transferred to our facility for evaluation of left-sided neck pain and swelling. He complained of fever and upper respiratory tract symptoms with rhinorrhea and sore throat 1 week before presentation. On admission, he was normotensive, tachycardic, and had low-grade fevers. His initial blood work was significant for neutrophilic leukocytosis 17,000 but lymphopenia 14.7%. CRP 16, drug screen negative, A1C greater than 14%. Other labs were unremarkable. On imaging with CT neck, confirmed deep venous thrombosis of left external jugular vein extending into left subclavian and brachiocephalic vein with patchy bilateral airspace opacities consistent with multilobar pneumonitis. Also, as evident in image 2, CT showed edema of subcutaneous tissues consistent with acute DVT. CTA of chest showed bilateral septic emboli, and on transthoracic echocardiogram, ejection fraction was normal and there were no signs of endocarditis. Patient was started on treatment for septic thrombophlebitis with broad-spectrum antibiotics and anticoagulation. As it is very unusual for a young patient with no significant past medical history nor IV drug abuse to develop this rare, life-threatening condition, we suspected some immunosuppression status. He tested negative for COVID PCR multiple times, but his antibodies were positive with quantitative IgG 58 establishing recent COVID-19 infection given his upper respiratory symptoms a week prior. His viral panel was positive for Epstein-Barr virus PCR, parvovirus IgG and IgM, thus suggesting reactivation of both Epstein-Barr virus and parvovirus secondary to recent COVID infection. All his cultures, including the cultures obtained at outside facility, remained negative, likely because of early initiation of antibiotics before samples were obtained. He was treated with linezolid, piperacillin tazobactam, and clindamycin, but did not show any significant improvement. Further, his clinical status worsened with parotitis, with redness and induration spreading to left side of face and postauricular area. Upon escalation of antibiotics to meropenem and linezolid, he showed significant improvement in parotid swelling and induration of face and neck. We discharged the patient on apixaban and IV ertapenem for 4 weeks to be given through midline and follow up with infectious disease clinic as an outpatient. To summarize, Lemierre syndrome is a forgotten, rare, life-threatening condition in which an oropharyngeal infection typically from Fusobacterium necrophorum progresses to sepsis and thrombophlebitis of internal jugular vein. Our case is an interesting one as Lemierre usually involves internal jugular vein and external jugular vein involvement is rare and only few cases have been reported in literature. Patient's recent COVID infection has caused his hypercoagulable and immunosuppressive state, increasing the risk of venous thrombosis and secondary infections. Also, we could say that his undiagnosed and uncontrolled diabetes has further augmented his risk. Treatment of Lemierre syndrome involves full-dose anticoagulation and prolonged course of broad-spectrum antibiotics. Thank you all for listening.